Hello, everyone, and welcome to this another running and menopause webinar. Tonight, we are looking at two really important, well, one really important concept, but in particular for female athletes, and that is low energy availability and RED-S, relative energy deficiency in sport, or relative energy deficiency syndrome. And I'll let Dr. Kate Ackerman go through that in a lot more detail and explain all of that. I see we already have a couple of people joining, so that's amazing. Please, guys, jump into the chat. Let me know. I see Janet in there, and Janet saying, what age group is this appropriate for? Really, we're aiming towards peri and post-menopausal females, but I quite like to say, that's essentially 40, 45 plus. But I would like to say that people from the age of 35, and really this is appropriate for most female athletes, but if you're 30, 35 and up, that is definitely appropriate. If you running or doing any kind of endurance sport, this is definitely appropriate for you. But if you wouldn't mind jumping into the chat, letting me know where you're from. We always have tons of people. I mean, I'm sitting here in Johannesburg in South Africa. Dr. Ackerman's in Boston in the US. There we go. I see some people signing in from San Diego. So that's really cool. Last week we had some people from London, hopefully South Africa. So yeah, let me know where you're from, and then we can get cracking. So much to learn tonight. Really grateful that Dr. Ackerman is here with us as well. So let me get into some introductions quickly before we get started, and then I can hand over to Dr. Ackerman. There we go. I see everyone chiming in. So we've got everyone from Scotland, from New Orleans, from New York, from Dallas. So that is amazing, guys. And we love the chat. So keep that going as much as we can. So tonight, guys, what we're going to discuss is everything females need to know about fatigue and running, and how to fuel for our running in particular. If you don't know me, my name is Shona Hendricks. I'm a former head of sports science at the University of Pretoria. I have a postgraduate degree in sports science at MBA, and I'm a certified strength and conditioning specialist. I'm the creator of the Running Through Menopause training framework that we use at coachperi.com. And I'm also a runner and triathlete myself. I've done a number of international world marathon majors, a couple of ultra marathons, as well as a few half Ironman distance triathlons. But really the expertise here tonight is Dr. Kate Ackerman. Dr. Ackerman is an associate professor at Harvard Medical School. She is also the founder and director of the International Biennial Female Athlete Conference, which is happening again next year, June, which we can talk about a bit later. And she's also the director of I don't even know how to pronounce this when I read it myself, the WUSAI, is that correct? WUSAI Female Athlete Program at the Boston Children's Hospital, and yeah, an innovation hub of that WUSAI Human Performance Alliance. She is also a former US national team rower and chairs up the US Rowing Medical and Sports Science Committee. She is heading off to the Olympic Games again this year with the US Rowing national team. And again, yeah, so she co-chairs that US Olympic and Paralympic Women's Health Task Force, and works as a consultant for the International Olympic Committee, and has produced and been a part of over 150 different scientific papers involved in women's sports and everything to do with women's physiology and they are. So Dr. Ackerman, welcome. Thank you very much for joining us in Boston.
Thanks for having me. Good evening.
Brilliant. So yeah, as I see, there are tons of people tuning in. I see we have someone from Madrid even as well, some people from Canada, Pretoria, South Africa, Philadelphia, London. So yeah, all over the world, female runners, and hopefully a lot to learn here. So yeah, let me just get started. And what to say is also, guys, we love questions. What we'll do is we'll want to get through Dr. Ackerman's presentation, and then we'll stick around and do a Q&A afterwards. Keep the questions coming in the chat, and I'll flag them as we're going through. If there's ones I can answer as we're going through, I will answer them, but we'll flag them, and we'll have a nice long Q&A afterwards as well. All right. So Dr. Ackerman, thank you very much. And yeah, I'll hand over to you.
Thanks. So we are going to talk a bit about relative energy deficiency in sport, or REDS, and give a bit of an overview of the updates of that model and some of the current concepts. Here are my disclosures, just my grant and research support. I am a paid consultant for various organizations. And as mentioned, I was part of the REDS working group and the Female Athlete Health Working Group at the IOC. So the objectives are really to discuss very quickly the dearth of research on athletic menopausal or post-menopausal women, describe the evolution of the female athlete triad to relative energy deficiency in sport, explain updated screening approaches to REDS using our new REDS clinical assessment tool version 2, or the REDS Cat 2, and then to discuss treatment and various prevention strategies for low energy availability in REDS. So this is literally my whole slide and what we know about menopause in female athletes. So a couple years ago, we decided to do a review and to just define our research priorities. We wanted to know what was out there when we talk about female athletes who are in that perimenopausal or post-menopausal stage in life. And we were pretty strict about our criteria of what is an athlete by using the McKay et al. Criteria. So we said tier 2 or higher. So that basically is somebody who's working out at least 3 times a week with an intention of competing at least once a year. So for most of you on this call, that's not a very high bar, but we wanted to make sure when people were describing physically active people that that was the benchmark that they were meeting. And so in our review, we searched 6 different databases. We defined athletes as mentioned. And what we ended up finding once we went through all of these different papers is that of almost 1,600 papers in the literature, there were only 22 that met those criteria. So just think about that for a second. 22 studies about health or performance. And the research question was, how does menopause affect health and performance parameters of female athletes? The papers were from 1984 through 2022. And so in that approximately 40-year interval, 22 papers. And when we broke them down according to themes, there was 1 on training, there were 10 on nutrition, 8 involving the cardiovascular system, 5 involving bone, and then 11 talking about endocrinology and metabolism. And unfortunately, what we learned is they were all done differently. They weren't meeting the same kind of stringent protocols and descriptions of things that we would like. We've also published a paper talking about what are best practices when studying female athletes, and these really didn't hit the mark there. So we have a lot of work to do. They didn't necessarily divide the subjects up according to being on hormone replacement or not. So you get the idea. So if I'm being brought onto this podcast or this webinar tonight to talk about all the wonderful things we know about menopause and exercise, I have to say we have a lot more to learn, especially when it comes to REDS or relative energy deficiency. So I want to give a quick background of how we got to that term REDS. So back in 1993, this term female athlete triad came to be, and that is the interrelationship between low energy availability, bone health, and menstrual function. And a lot of that was really based on the pioneering work of Barbara Drinkwater, who is who we consider the godmother or grandmother of the female athlete triad. And the idea was in the 80s, she was noticing that women who were exercising would lose their periods, and then they would have a lot of fractures and have osteoporosis. And as she teased it out more, she realized many of them had eating disorders. And over time, there was this focus on whether they were eating disorders or not. It could be just not enough calories for how much was being expended or how much energy availability there was. So there was a position statement. The first use of that term came out in 1993. The first ACSM position statement around triad was in 1997. There was an update in 2007 and then an update in 2014. And over time, it was clear that there was a continuum. You might see an athlete who presents with low energy availability, but they haven't lost their period yet. Or they might have had low bone density, but it's not clear that they've had menstrual dysfunction. And so not everything is presenting all at once, but there are these 3 spectra, and people can go from optimal energy availability on the right, all the way down to this low energy availability, this functional hypothalamic amenorrhea, because it has to do with signaling in the brain at the hypothalamus that's disrupted, and then low bone density. That same year, 2014, the International Olympic Committee updated their female athlete triad position statement and decided that they were, quote unquote, moving beyond triad and came up with this term relative energy deficiency in sport, or REDS. And they came up with these 2 wheels that you can see. One was talking about health consequences, and the other one was talking about performance consequences. And you'll notice that there's this little red triangle in there. So in the model, there was still low energy availability that involved bone dysfunction or poor bone health and menstrual dysfunction, but that there were other things that were happening too. So there were GI consequences, there were hematologic consequences, et cetera. The other little circle that was up in that right-hand corner is the performance outcomes. And I think this was one of the reasons I like this model is I see a lot of athletes who might not care that they don't get their period. They might prefer they don't get their period. But if they're having performance consequences, that's a really great hook to get them to maybe think about what energy availability can do to help them perform. So this paper came out in 2014. I then joined the group after that and was really lucky to be part of their 2018 update. And it was also noted in that 2014 paper that this doesn't just happen to women. Low energy availability can happen to men as well. So then in 2021, the Female Athlete Triad Coalition updated their statement and they came up with a male athlete triad. And so now they have the Female and Male Athlete Triad Coalition. But we keep going with this REDS concept. So in 2023, we have new wheels, we have new updates, and there's a new paper or series of papers that came out in September of 2023 in the British Journal of Sports Medicine, most of which are full open access. So we'll talk about that a little bit, but if you want to do more reading about it, there are a lot of different papers describing REDS, treatment approaches, prevention, what are the different signs and symptoms, et cetera, in that special edition. So as an endocrinologist, I'm very interested in the fact that low energy availability leads to a lot of different endocrine disruption. So if you are a premenopausal woman, we expect that low energy availability can cause you to lose your menstrual cycle. It can cause a drop in FSH, it can cause a drop in LH, and those then are stimulating the ovarian production of hormones. So there's going to be a drop in estradiol and androgens. But there are other signs, and I think that's where it's really important in our male athletes and in our postmenopausal athletes. We don't necessarily have to rely on a menstrual cycle to see if somebody is in a state of low energy availability. When somebody is in that LEA state, they also can have a decrease in T3, they can have a decrease in leptin, they might have increases in cortisol, and they have an increase in growth hormone resistance. So all of the things that you see on this slide are the disruptions that happen with low energy availability. They don't all happen at the same time. Something that will keep me busy for the rest of my career is figuring out the exact interplay with these different hormones and why in some person FSH might drop pretty quickly, and then in another person IGF goes down, in another person T3 gets disrupted. So it's not always linear. There are certain hormones we expect to go down or fall first. So T3 is a pretty sensitive marker, that thyroid hormone, but we are all different, and so there might be different markers in different people. Everything in this slide that is green is something that is very positive for bone density and bone health. Everything that is red is negative for bone health. So you can see the arrows are going in the wrong direction in terms of things that would be beneficial for bone. I expected these to be fly-in, so excuse me as I see the crossover there. But the idea here is that relative energy deficiency in sport is a syndrome of deleterious consequences of low energy availability that can happen in females or males. It's when they are exposed to problematic low energy availability. So this isn't just skipping breakfast. This is usually prolonged or severe low energy availability. And it has to do with inadequate energy intake in relation to exercise energy expenditure. So when we talk about how often this happens or who is susceptible, we've looked at a lot of different studies in the literature, looking at over 120 papers talking about LEA. The estimated prevalence is about 23 to 79.5% in females. So it depends on what sport they're doing. It depends on what paper was published, when it was published, what methods they used, and around 15 to 70% in male athletes. So a little less in the males, but there's still this huge spread, and it depends on the population. Is it an aesthetic athlete? Is it someone in endurance sport like running or in triathlon? We do see this more commonly in people that are in weight-restricted sports like rowing or jockeys. So these are the populations that definitely have higher incident or prevalence, but we can see it in any type of athlete. I've seen this happen in football players, or American football players, I should say. We've seen it happen in the other type of football that the rest of you call football that we call soccer. So it happens in all sports. Climbing is another sport that is at high risk as well. So in 2015, we developed this REDS clinical assessment tool. This was a pretty quick attempt at screening, and we didn't have a point system for it. It was basically like a traffic light of green is fine, yellow is their moderate risk, and high risk was red. And high risk really meant no start. So we didn't give it a point system because we felt if somebody has significant anorexia nervosa, they should not be competing. We don't need to give them a whole bunch of points to say that's dangerous. If they have severe ECG abnormalities or EKG, then that's also a no-go. We don't want to put them in a situation where their heart is at risk and, oh, whoops, they didn't score enough points. So we really didn't use a point system. We kind of thought of all the different factors that could be brought up and which ones would be the most medically unstable or dangerous and made those the red light. Yellow was sort of a catch-all for people that needed to get plugged in and get more resources, but they could continue to compete and practice. And then green light was they have checked all the boxes, they're good. However, when we tried to test this out, we did it looking at 1,000 female athletes presenting to our clinic. So I work at a children's hospital where we do see kids and adults, which I know is a little odd, but we focused just on 15 to 30-year-old women for this. And unfortunately, these are people coming in for anything, concussion, ankle sprain, you name it. 96.2% of our population scored in the moderate to high risk category. So that was a wake-up call for me and our group. We just thought, well, we can't say 96% of our athletic population coming in with a simple sports injury is in that medium to high risk. We have to be able to delineate and determine how sick people are and be able to help them work through their training if they are medically stable. So we then updated, our group of IOC folks updated this REDS CAT, and we'll get to that. So in September of 2023, this edition came out. This was a culmination of about 2 years of work with this international group that I am very proud of and happy to call my friends. This is the journal edition, and you can see there was some editorials in there. There's discussion about male athletes. There's discussion about lactation and having REDS. There's discussion of our full IOC consensus statement, talking about how we should study this going forward, really looking at all these subsets of the REDS models and making sure that we're doing good research to understand the pathophysiology, and we want to get more people in this space to help us. We talk about the development of the REDS CAT and how that was tested, and then some of the primary, secondary, and tertiary prevention approaches to REDS. We do focus on the mental health piece. This can be extremely stressful for our athletes when we tell them, hey, we need to change how you're eating. We need to change how you're training. We might even be pulling you from activity for a while. That can be extremely disruptive, especially with these high-level athletes who are really dedicated to their training, and then to be told they've been doing it wrong and we might be changing their lifestyle for a bit. So as we look at these updated models, we still have the health and performance wheels, but we added a few things to the health wheels based on the data that are available. And we took away a couple things in performance that seemed like they were a little redundant. Specifically, some of the added impairments were urinary incontinence. So there are studies now demonstrating that women who have low energy availability have issues with their pelvic floor. It might be also related to estrogen receptors, and they have more urinary incontinence, specifically stress incontinence. There are definitely are papers that discuss low energy availability affecting neurocognitive function. Low energy availability certainly affects sleep. There is reduced skeletal muscle function in states of low energy availability, as well as impaired glucose and lipid metabolism. And again, all of these things exist on a continuum. So the model now puts low energy availability in the center, and then people are in a state of REDS when they get to that pathologic state, when they're out in the red circle on the external component. In terms of performance, we see decreased athlete availability. What does that mean? Basically, is an athlete able to show up for practice and participate? If they're injured, they have less availability. So it's how many practices they're able to complete. And we find that with low energy availability, they're either injured or they're out sick, or they've been restricted for different reasons. They have less availability to do their workouts. They have a decrease in training response, decrease in recovery, decreased cognitive performance and skill, decreased motivation, muscle strength, endurance performance, and power performance. So this is just an example of what the IOC REDS CAT 2 looks like. That's the QR code. This is one of the free journal articles that came out. And the idea is you can use this if you are a coach. You can use this if you are an athlete yourself. You can use this if you're a physician or a medical provider to screen an athlete, at least get the steps started in doing the screening. So it has 3 steps. Step 1 is basically population-based. So let's say somebody is screening an entire cross-country team. They're able to do these questionnaires and do a clinical interview. This, of course, has lower sensitivity and specificity, but it's inexpensive. It's easy to use. It's easy to use with a group. And so it allows questionnaires for large athlete group screening. If somebody screens positively a bit, if they're greater than low risk, then they go to step 2. And step 2 has high sensitivity. It is more expensive because it's bringing more testing. But this clear scoring now allows for easy and reliable implementation. And then if somebody scores in the higher risk categories, and we added a category, so we now have green, yellow, orange, and red. So if somebody's in the yellow, orange, or red, they proceed to step 3. And here's where we bring in the physician. There's a physician diagnosis based on some of the information they gathered from step 1 and step 2. And then they are doing more of that clinical history and an examination and ordering more laboratory testing. This then involves individualized treatment plan and having developed and then using a multidisciplinary or interdisciplinary treatment team. So step 1, again, part of an annual exam. This can be any time that somebody's coming just to do a regular PPE or pre-participation exam. It can be when an athlete presents with disordered eating or eating disorder, if they've had weight loss or fluctuations in their weight, if they have fallen off of their growth curve for some of our younger athletes, if they have known endocrine dysfunction. And so that gets tricky. You know, if we're talking about post-menopausal runners, is this somebody who's lost their period fairly early on? They seem like they're not at the age where you would expect menopause to be occurring. So they should have a red screening to make sure that that's part of the differential diagnosis and not just assume the runner's going through menopause. Have they had recurrent injuries and illnesses? Have they had bone stress injuries? Have they had decreased performance or performance variability? Have they had mood changes? So this is the QR code to explain how we validated our REDS CAT. In a nutshell, we came up with these categories. We screened over 200 athletes to look at some of these markers. We developed a scoring system, doing statistics on some of the outcome measures. And then we wrote up case scenarios and we graded those scenarios based on our REDS CAT. And we shared those scenarios with medical professionals around the world. So they were our expert panel. And we asked them what category those patients or those pseudo cases what category they would fall into. And we had great correlation between our REDS CAT and what the experts said. And so our correlation there was 0.885. So pretty good for a screening tool. But like anything, we are completely open to the fact that this will have different iterations as we learn more over time. And so the idea is green, again, is going to be none or very low risk. And we have a scoring system of primary indicators and secondary indicators. Yellow, that's mild risk. Orange is moderate to high severity or risk. And then red is very high or extreme risk. It's hard to read on the slide, but at the bottom, there's this little gray box, and it talks about kind of don't pass go, serious issues where we don't need a point system. So if somebody has extreme orthostatic hypotension, so when they go from lying to standing, they have a significant drop in their blood pressure. If they have a significant increase in their heart rate as that happens to try to compensate, or if they have extreme bradycardia just at baseline, those would be absolute no-goes where they need more of an evaluation before we would just clear them. So there are a few things that don't fall into the scoring because they just mean stop where you are and do more of a workup. So primary indicators, the severe primary indicators, are people with primary amenorrhea, meaning women who did not get their period by the age of 15. Another primary indicator would be prolonged secondary amenorrhea. So somebody has had their period and then they lose it, and it is due to functional hypothalamic amenorrhea. So notice that's in there. It's not because someone went into menopause. It's not because somebody developed polycystic ovary syndrome, but it's actually been worked up and there's no other explanation for it, or it has been determined that there's functional hypothalamic amenorrhea. And then for males, a severe primary indicator would be clinically low, free, or total testosterone, meaning they're below the normal range. We then get primary indicators. So the severe primary ones get 2 points, the primary ones get 1. And so a primary one would be secondary amenorrhea. it would be not the prolonged, but just secondary amenorrhea. Then we have subclinically low free or total testosterone, meaning it's the low quartile, the bottom fourth of normal range. Subclinically or clinically low total or free triiodothyronine, or T3, a thyroid hormone that is a great marker of this. Then we get into the bone issues. So history of one or more high risk, meaning femoral neck or total hip or sacrum or pelvic bone stress injury, or two or more low risk bone stress injuries. So these are the other locations like metatarsal or tibia in the last 2 years. So we really wanted to put a time window on this. So if you are 50 and you are getting stress fractures now, that is much different than if you are 50 and you haven't had a stress fracture since you were 15 years old. So we said 2 years in the last 2 years, or if you've had an absence of 6 or more months from training due to the bone stress injuries in the last 2 years. We used our bone density cutoffs. And so this is important to realize when we talk about REDS, so much of this is based on premenopausal women and in men. So when we talk about adults or adolescents or children and adolescents getting bone densities, we're using Z-scores. And so if you get a bone density report, it should have a Z-score to it. And that is comparing your bone density to people of your age if you are premenopausal or if you are a male under the age of 50. And so the cutoffs here are really about the location of the DEXA depending on the age group. So if it's an adult or someone over the age of equal to or over 15, but you're not postmenopausal and you're not over 50, then we use a BMD Z-score of less than -1 at the lumbar spine, total hip, or femoral neck, or if the bone density is dropped. In a child or adolescent under 15, we use a BMD Z-score less than -1 at the spine, or the total body less head, or a decrease from a DEXA from prior testing. Then we have secondary indicators. So this is things like oligomenorrhea caused by functional hypothalamic amenorrhea. So greater than 35 days between periods. If they've had a history of one low-risk bone stress injury within the past 2 years, an absence of less than 6 months from training due to that injury. And then elevated total or LDL cholesterol above the reference range, or clinically diagnosed depression and or anxiety. But here, both of those things would only count as 1 point, even if someone had both. This is a list of potential ones, and I don't need to walk through all of them, but the idea is we didn't have enough research data to say that they should be in the model, but certainly clinically and anecdotally, we see that these things run along with low energy availability. And we hope as more research is done that we get enough data that we can include it in the model in a way that's meaningful. So things like a young person who has not been growing, their IGF-1 is low, that can happen with malnutrition, so that would count. Sometimes clinically low blood glucose or clinically low insulin. Iron studies have been correlated. So this is just a list of other things that will probably become part of the model at some point as we do more work. So as I said, here's the QR code of the risk assessment, and you would be able to plug in the high risk, the low risk, the severely high, or sorry, the point system, like the severe points and the less severe points, and see how it adds up. So do they have primary indicators? Do they have secondary indicators? And where do they fall? And then there is an online tool that would just plug it in. If you don't like doing the math, then you can just plug it in, and then the math is done for you online so that you can score people. And then we get to the third step. So this is just how much of a risk they're at. And then we get to step 3. And this involves the diagnosis happening with the physician and coming up with the treatment plan. And a lot of people forget about this when we talk and do REDS talks around the world. They think, well, not everything is REDS. Does REDS even exist? There are so many causes for these symptoms. But the point is, it does exist. You just have to make sure that you're ruling out other things. So you can look at this list and see, if we're talking about menopause, for example, a lot of people in menopause have these symptoms. So REDS is not just about the symptoms, it's about the cause. The low energy availability has to be the cause of the symptoms. And that is our job as physicians, as sports dietitians, and other people to sort out what is the cause of somebody's symptoms. So I might have a woman who comes into my clinic who's a runner. She's 58 years old, and she went through menopause 5 years earlier. She definitely had hot flashes back then. She definitely had some weight gain. She had memory loss. She had her menopausal symptoms, but she got through it. Now she's 58. She's training for a marathon. And she's talking about bloating, and she's talking about fatigue, and she's talking about stress incontinence. that may be different. That might be that she's not fueling enough for her marathon training. So it's important that we look at that differential diagnosis and we think about what are the other causes of things like losing a menstrual cycle. If it's a younger person, are they pregnant? If it's a woman in her 40s, this could be her last hurrah and she is pregnant because it's right before she's going through menopause. This is a time when some people have those special surprise kids. Is it because someone's on hormonal contraception? Is it because of polycystic ovary syndrome? Do they have a pituitary mass, such as a prolactinoma? So we have to think through all the different causes. That is what then leads us to this idea of a syndrome. If they have things in a few categories and we have a story that makes sense for this syndrome. I also like to think about what is the time course that some of these things have happened. And so when we talk about how long someone is in low energy availability and how long it takes to get to the outcomes, there's some things that will happen relatively quickly, and there's some things that will take a while. So if we think of acute changes, T3 can go down very quickly. Leptin will go down very quickly. Resting metabolic rate can change pretty quickly when someone's been in a state of low energy availability. When we talk about more weeks to months, that's the midterm. So that's the hemoglobin mass dropping, or training adaptations or changes in performance, or the menstrual cycle disturbances developing, or libido being affected, which is a huge marker for our male athletes. Is definitely a decrease in libido. For our younger male athletes, they might have gone from having morning erections every morning when they wake up to not having that anymore because of the drop in testosterone. So some of those changes will involve being in a state of low energy availability for weeks to months. And then we have the prolonged low energy availability. So it could take months to years to have the effect of low bone mineral density, or having an increased risk of bone stress injury, or really developing this eating disorder, disordered eating behavior that really is hard to break. Exercise dependence, infertility, those are things where it takes a long time to be in that state of LEA to develop. When we talk about our screening, we do involve DEXA, and I realize that that is not available all over the world. That can be cost prohibitive some places. I have a lot of colleagues that I do research with in Canada, and it's harder for them to get a DEXA covered. In our clinic, we have it available for all of our patients. It's pretty easy to get it covered by insurance in the United States, but that's not the case for everyone. And so we do have to keep in mind that as we're using our REDS CAT, or we're trying to screen for REDS, some tools might not be there, and then we'd have to change our grading system a bit. But in general, the DEXA looks like that picture to the left. We do get the option for our kids and our younger adolescents, that whole body scan. And then because that's been done, we can easily get body composition. So that picture to the right is looking at body composition, where bone is blue and muscle is red and fat is yellow. Some places don't scan the whole body. So if you're at an adult institution and they're just scanning spine and hip, you might not get that extra picture. But it is possible to do that on any DEXA. And if you have the right software, where it can be adapted to your machine. So when treating REDS, it is a multi or interdisciplinary team. It does work better if you have a lot of different people available to you, but you've got to be creative. Not everybody has all of these specialists in their community. So in an ideal world, you would have a physician helping take care of any of the medical problems that are coming up and guiding the whole treatment. You'd have a dietitian or nutritionist to help go over the caloric intake for how much is being expended. You'd have a supportive coach who's on board to modify the training to support their athlete as needed. You'd have a mental health specialist to help the athlete get through what is the drive behind their energy restriction, or how are they coping with the fact that they've been pulled from some of their sports participation. You'd have a physical therapist who's helping them with any of their injuries. You'd maybe have somebody helping them with their training plan. You'd have an athletic trainer if they're at a university setting or in a place where they need some hands-on work and someone to help monitor them more often than the physician. And then you could have an exercise physiologist as well, who's helping to drive the training program. Overall, the goal is to promote rehabilitation to prevent or limit short and long-term severe health consequences of REDS. So certainly it requires correction of the energy deficit, and that's going to happen through increased energy intake and or decreased energy expenditure. but we need athlete buy-in, and often they need proof. And so that's where providing data can be very appropriate in certain situations. So if we show them labs and we show, hey, your iron stores are really low, your white blood cell count is really low, your T3 is low, your testosterone is low, and you're showing all these numbers and making a story as to why that's happening, that can be helpful for the athlete to understand. Body composition, I don't like to focus on numbers, but we do see, at least in our female athletes, when their Z-score for percent fat, just like we're using a Z-score for their bone density, when the Z-score for percent fat in our younger women, we have not done this yet in our post-menopausal women, is below -1, we often find that they are losing their period and they're in a state of LEA. Certainly in menopause, we can't use the period correlation to the body comp. So we need to do more studies in menopause to see what do we expect on DEXA in an athletic population where a certain percent fat below that would be of concern. Other things to give athletes proof are performance measures, and then seeing the changes over time. You know, at first, athletes who are energy restricted will say, well, I've been running the best of my life. I don't understand why you're focused on me just because I don't get my period. You know, I see other people on my team who are thinner than I am and they're not getting focused on. It can be really hard to tell them to change what they're doing. But usually at some point, they will find that they're having a problem. Either they get injured or they start to fall off in terms of their performance. And then when they do have to change their diet and they do have to change their training, they come around again and they say, you know what, I actually feel better. Actually, my performance is getting better, or I'm sleeping better. And so those are really satisfying situations when they themselves can see the changes over time. So in assessing low energy availability, this comes up in our consensus statement. We're actually getting away from really, really strict measurements of LEA. It turns out there are no standardized protocols for energy availability assessment. It is ideal to measure exercise expenditure during multiple days of activity. So people do different types of workouts. They're going to expend calories differently on those different days. We know that low energy availability states can develop at varying times of training. So it might be as people are leading up to a major competition, or it might be when they're putting a lot of volume into their training and not so much during the taper before their high level competitions. Overall, it's just really helpful to work with a sports dietitian or nutritionist, because this person's going to go through their diet, talk about what the timing is of their food, the types of food, the macronutrients, the micronutrients, the recovery snacks. Sometimes that can be a lot more helpful and informative than just finding out the exact number of calories somebody's eating. And then when we treat RED-S, we want to think of a lot of different things. Going around this circle quickly, we want to be mindful of eating too much fiber. So if someone's having so much fiber that things are just going through them, they're not going to be absorbing the nutrients that they need. We want to optimize carbohydrate intake. And certainly there are a lot of people in menopause who start to gain weight and they think, well, the best thing I can do is have fewer carbohydrates and exercise more. But it's a bit of a catch-22, because when that happens, you're putting yourself into a state of low energy availability. And we know that low energy availability and low carbohydrate, both independently and synergistically, are going to lead to RED-S outcomes. So carbohydrate deficiency, if you have a diet that is adequate in calories, but you're not getting these major groups like carbohydrate, there can be issues strictly from that. When we talk about the energy deficits throughout the day, when somebody is doing so much fasting that they're having their meal all at one point in time, if they're just eating dinner, that is going to disrupt the metabolism. So we have to talk about within day energy deficits and make sure that people are keeping their metabolism up by eating enough throughout the day, so the body's not just holding on to whatever is put in it and slowing down the metabolism in the process. We want to focus on bone building nutrients, so calcium and vitamin D, certainly incorporating strength and resistance training, especially as we're in menopause, and then recognize and reduce psychogenic stress. So when somebody is stressed, whether physically or emotionally, that's going to cause a rise in their cortisol. When they also are in a state of low energy availability, that will cause a rise in cortisol. And cortisol is detrimental to bone. So we have to take into the fact that those hormone changes are going to have negative impacts. And even just psychogenic stress alone can cause somebody to lose their menstrual cycle. So they've done studies looking at women who are trying to get pregnant, who are really stressed in the process, and then found when they did an intervention about fertility and talking about these issues, they were able to conceive better because they were able to relax in the process. So there is this mind-body connection, especially when it comes to the endocrine system. Going around this wheel quickly up at the top, impaired reproductive function. So we don't want to put people on oral contraceptive pills. That is going to mask the low energy availability issue. We won't know if somebody's eating adequately if they're now getting this withdrawal bleed that is because of the exogenous hormones you've put in the system. In terms of bone density, you want to make sure they're getting adequate calcium and vitamin D, that they're meeting the daily recommended allowances. We can talk about medications if people have questions about delayed bone healing or low bone mineral density, depending on the age of the athlete and the severity of their bone issues. In terms of GI issues, so small nutritional changes can help at a time, and sometimes cognitive behavioral therapy and medications can be helpful temporarily as we're trying to get the GI system to run smoothly again. In terms of energy metabolism and regulation, this is another one where small nutritional changes are going to help get the metabolism going. Impaired hematologic function, sometimes in concert, you might want to be putting somebody on iron if their ferritin and their total iron is really low. If their total iron binding capacity is elevated, you want to replete that iron as necessary. Urinary incontinence will improve with improved energy availability, but can also be helpful to involve pelvic PT and some lifestyle modification. We get to impaired glucose metabolism. Here, that does improve with increased energy availability. Mental health should definitely involve psychological counseling. Sometimes some people need medications as well. That impaired neurocognitive function improves with increasing energy availability, as do sleep disturbances, as does cardiovascular function. If they are in a restricted situation that is dangerous with cardiovascular function, then you might want to have very close monitoring. So it depends on the severity of their REDS outcome. Their skeletal muscle function will improve with this increased energy availability, as will growth and development, as well as immunity. So again, kind of hitting this point home, energy availability is the key in terms of the treatment. And these other things are adjunctive. So they're things that we can add as necessary from patient to patient. So how do we prevent this to begin with? So we have this primary, secondary, and tertiary prevention. This is another one of our open access papers. Primary is really, let's not have somebody even start having RED. Secondary is let's make sure they don't get it again. And tertiary is treating it. So I like to think of our athletes as these really high functioning, awesome race cars. And we don't want our race cars to just go flying off the cliff to a point of no return. We got to be their pit crew and take care of them as we go. So primary prevention is really focusing on education about the importance of adequate energy availability to ensure optimal health and performance. We want to teach adequate fueling strategies for various training duration and intensity, as well as growth. So during adolescence, what does that mean? We also need to be thinking about teaching fueling strategies for people as their metabolism slows and as they're getting into that phase of life where their estrogen is dropping and their testosterone is dropping and their metabolism is slowing a bit. This isn't a one fit for everybody. One size does not fit all when we're talking about a 14-year-old girl versus a 65-year-old woman. And then we need educational initiatives targeting athletes and their entourage. So we need to be talking to coaches, talking to parents, talking to other people in the sports performance field. And we want to strengthen protective factors and reduce risk factors. So protective factors. So protecting self-esteem and inspiration, strengthening positive body image. We want there to be acceptance of physical changes related to adolescence, as well as physical changes that happen as we get into menopause. We want people to be smart about the media. Don't believe everything you read. Don't believe every TikTok. And we want to actually have good information out there about balanced nutrition and training. We want to reduce risk factors. So this internalization of an ideal body type. What is ideal? We can't all possibly look the same and have the same percent fat and have the same BMI. We want to reduce body dissatisfaction, reduce peer pressure and fat shaming. And sometimes with elite athletes in particular, there are going to be times that there is intentional exposure to low energy availability that is needed to reduce body weight or body fat. And so this is a picture of Trent Stellingwerff Trent Stellingwerf's wife, Hillary. So I should say Hillary Stellingwerf. I was forgetting for a second. So Hillary Stellingwerf is an Olympic athlete from Canada, a lovely woman whose husband was also her coach, or is her coach. And so they worked very carefully together to modify her training and modify her nutrition so she could get down to the ideal weight when she needed to at the Olympic level, at the Olympics, and then gain weight where her body would function completely appropriately. She was able to go to the Olympics, have a baby, and go to the Olympics again. And they have tracked everything that she did in terms of her weight and the timeline. So this is a really interesting article that they wrote in IJS, in the International Journal of Sports Nutrition and Exercise Metabolism back in 2018. So they're basically using Hillary as the test case and describing the training that they did. So we can consider doing this nutritional weight loss program in elite athletes only. It really does require careful planning. We want to ensure that athletes have physical and psychological readiness. We want to use evidence-based rationale and set realistic goals. We want to involve a multidisciplinary team, maintain energy deficits in moderation, and not do any assessment or body weight and composition unless it's for medical purposes, if it's for someone less than 18. So there needs to be a level of maturity to be doing this and to do it well. Primary prevention also includes non-modifiable risk factors. So can we start talking about why there are weight classes and what those weight classes are? What is the timing of the weigh-in? What are the outfits that the people need to wear? Do we need our beach volleyball players to be looking like supermodels, or can we just let them play volleyball and not be objectified in those tiny little bathing suits? Should we be advocating for rule changes? So should we adjust weight categories? Should there be BMI cutoffs? These are really controversial areas that a lot of us have talked about and talked to different sporting organizations about. It's not a simple answer. I'm not saying that any of these are simple answers, but they're things that we should be thinking about. Uniform changes, for example. Then we get to secondary prevention. So early identification and management of red signs and symptoms. We want to do this so that we recognize it so we can facilitate early treatment and therefore prevent more serious REDS outcomes like osteoporosis and eating disorders. And then there are various methods that can be used. So self-reported screening instruments or individual health interviews, just observing the athlete and seeing changes over time and kind of nipping things in the bud if we're seeing that an athlete has developed maladaptive behaviors. And we can also use objective assessment of REDS markers. So those labs, for example, and the DEXA. So we have to listen to and observe the athlete. Do they have physical symptoms? So menstrual dysfunction in females, erectile dysfunction in males, recurrent illnesses or injuries? Do they have psychological symptoms, mood changes, reduced well-being and depression? And then behavioral effects. So are they participating in excessive exercise? Are they doing frequent non-performance related body weight or body composition assessment? Are they getting on the scale all the time? Are they always asking about their body comp? And have you observed disordered eating behaviors or eating disorders? So like I said, we're the pit crew. Our job is to be taking care of this high-performing athlete, and this is the tertiary prevention. So like I said, there are a lot of different things that can be added as part of treatment, but I think it's important to recognize that athletes can get better. And so this is a picture of the DEXA body comp on one of my patients. The left is her baseline. A year later, you can see that she's got much more fat on her body. Yellow is fat. And if you look to the right, you can see this increase in percent fat. So in that course of a year of treatment, her bone density actually went up, her percent fat went up, her performance improved, and her menstrual cycle came back. So REDS prevention is really about the primary prevention with sports leaders and organizations and people advocating for getting the information out there. Secondary prevention is really making sure that we recognize this stuff early and we can really treat people as soon as it's presenting. And tertiary prevention is doing significant treatment when it's happening, diagnosing them and taking care of that impairment and trying to prevent recurrence. So here's a picture of an athlete who was in a state of REDS, and later she came back and actually won an Olympic medal. And so I love when we have professional athletes out there who are on podcasts and who are on social media and on their own personal channels talking about the struggle they went through, because this is so common, and then coming out the other side and what they learned from it. So this is special thanks to a lot of our research staff and my international collaborators who have done so much work on REDS. And for more information, you can go to Red in Sport. That is one of the websites that we put together just for various resources and some of the articles. We also, as mentioned earlier, have a female athlete conference, which will be happening again next year in June in Boston. That QR code is available as well to learn more about these papers with the IOC. And then I'm also part of that WUSI Human Performance Alliance, which is a $220 million initiative that was provided by some wonderfully generous donors to help us enhance human performance. And I'm lucky that I get to focus on the female athlete component. And a big chunk of our time going forward is going to be focused on our menopausal women because we have been quite neglected over time. So thanks for listening.
Brilliant. Thank you so much, Dr. Ackerman. I'm going to leave that slide up, guys, if you want that QR code. A couple of people were asking about where they can get, the different images that you're using and so on. So I'll leave that up there for now. Maybe just to get to one or two of the questions that come up, and I noted down a couple as well as we were going through. So one of the participants was asking, could you address hysterectomy and or hormone replacements and how that affects REDS? And not sure if we have done any of the research on that yet, or your views, please.
Yeah, it's a great question. And I think one of the areas where I find there's just a dearth of information is when we talk about women who are on hormone replacement versus women who are not. That research has not been done. That's why we did that review to say, where should we start? More research than not has been focused on osteoporosis. And osteoporosis is a huge issue. And we know that estrogen is beneficial for bone. And we know that women who go through menopause and beyond should be doing strength training to help with their bones. But there have not been enough studies looking at people on HRT versus not. So any answer that I give is going to be theoretical about how estrogen affects your body. And we know that estrogen is a bit anabolic and progesterone is a bit catabolic. They seem to have opposite effects. So it would make sense that somebody who's on estrogen treatment would have more of an effect in terms of being able to help their bones. When it comes to REDS, we don't know enough about how people feel on HRT and some of the hormone signaling, the appetite regulating hormones that would affect their energy intake. So when we talk about energy restriction or an energy balance, sometimes it's because somebody is trying to make weight. Sometimes it's because they are focused on what they look like. Sometimes it's because they just don't have the appetite for food. So there haven't been any studies looking at postmenopausal women and how those appetite regulating hormones are affected on and off estrogen currently. All of that work has been done sort of in a premenopausal state.
Okay, because that was going to be my follow-up question was and I know I asked you this even before we met, but and if some of the notes I had here, some of the health decrements of REDS, I noted like brain fog, sleep disturbances, urinary incontinence. Sorry, excuse my stumbling over the words. But those are symptoms I know that many of the athletes that I work with struggle with from menopause. So I know there are differential diagnoses, but how would someone who's menopausal and running, then sort of go, well, is this REDS or is this just menopause? What would be the process for that person to go through?
So when we see those patients in clinic, it has a lot to do with the timeline. So if somebody is 45 and this just hit them like a ton of bricks, was there anything leading up? Most people don't some do, but most people don't go from having a period every month to just complete stop. It tends to get a little irregular. So if you've been doing the exact same training, you haven't just taken up marathon running, but you've been doing the exact same training, and then you've noticed the things that you used to do are not working for you, that's probably menopause. If you are changing your training load and you've decided, hey, I'm going through menopause, I think I'll be an athlete now, and now I'm going to train a ton, then it's very likely that you have put yourself into an energy deficit because you just didn't know better. And it is harder to lose weight as we're going through menopause. So that's where I really rely on my nutrition colleagues. So in the US, they are sports dietitians. They are certified. I know in other countries, a nutritionist means something different than a dietitian, but either way, someone who is certified and is an expert in sports nutrition can be really helpful there, because then you get a better sense of how many calories the person is burning, when they are eating, if they are in a low carb state. So that's their part. And then I can be testing other things. So if somebody is not in a low energy availability state, they shouldn't have a low T3 if they don't have known hypothyroidism. So they might have a normal TSH, and they could have a slightly low T4, and they could have a very suppressed T3, and that would make me think low energy availability. So not all of the hormones have to be related to the reproductive function. There can be other biomarkers that we can use.
Brilliant. Thank you for that. Yeah, let me just say here, I meant to put this up, guys. If you enjoyed what we were talking about today, please subscribe to the channel. We'll be doing more webinars like this, similar sort of process, learning more about, being female athletes, going through menopause and running. So yeah, hit the subscribe button there if you don't mind and you want to see more of this. Sabina was asking Dr. Ackerman, and perhaps related a little bit more to collegiate athletes, but firstly she'll say, how much of heart rate variability is linked to anything you're looking at with RED-S? And yeah, then the second question there is in and more around the collegiate athletes as well, but the question's up there for you.
So I'd say the heart rate variability component is being studied right now. There are different wearables that have reached out to us, and we have some studies going looking at how much that can be relied upon. There can be different reasons for changes in heart rate variability, but we're hoping that we can come up with an algorithm that makes sense. So we don't want to put all our stock in it. I'd say stay tuned. So that answers the next part. What are the standards? We don't know yet. How are the colleges using these scores? So keep in mind that this REDS-CAT2 is just rolled out. So we are in the midst of working with various schools to be able to do an intervention to test it. We've tested it in elite athletes. We've tested it in individual sports, but we're in the phase of now trying to test it at a lot of different universities. And of course, we run into the issue of, okay, well, when we find that we're scoring people, what do we do about it? And every school is very different because some have great resources. They have multiple dietitians, they have mental health, but some have none, especially when we get down to the D3 levels. So in the US, we have the NCAA and we have D1 schools. We also have D2 and D3. And so schools that have less funding are not necessarily going to have all the experts. So they have to be careful to not necessarily looking for things that they can't do anything about, which puts them in a tough position. So to get to our student athletes forbidden from competing, if not within range, if they are tested on the REDS-CAT, if this is actually being implemented and they fall into the red category, I'm doing that more in my clinical setting. So I would then, in a clinical setting, say, okay, if this is an adolescent, I'm telling the parent that this person shouldn't compete. And this is why I'm recommending a higher level of care, because this is really dangerous. So that might be they're going to a residential treatment program, or we're at least pulling them out of exercise so we can normalize their heart rate or their blood pressure. If it's in a collegiate setting, then that's going to vary depending on the doctor at that school. And are they taking responsibility for screening those athletes and then following the protocol? It's a mixed bag. It depends how much the school has devoted to really doing a RED screening, or if they're kind of putting blinders on because they don't want to find things out right now.
Yeah, 100%. Thank you. Nikki was asking in and around iron. And again, I think, you mentioned around things being a process and different diagnoses, but she says, you mentioned low iron stores. My stored ferritin is apparently very low, but I'm not actually anemic. Could that be affecting her energy levels? Is it a low energy availability? I mean, I know some of these questions are hard to answer just via a YouTube question, but yeah.
Yeah. So again, it's not, if your iron is low, that doesn't mean you have low energy availability. That means your iron is low. And so if you truly have low iron and low ferritin, you're not considered anemic until your hemoglobin drops to a certain decrease. But you can have iron deficiency that is not full on anemia yet. It's all a gradation. So you absolutely will feel tired if your iron stores are low, your ferritin and your iron are low, or even just your ferritin is really low. And it would make sense because ferritin is a sign of iron storage. You need iron for the oxygen carrying capacity. So you're saying you're almost always tired and out of breath. I actually love finding levels like that because I can fix it. We put you on iron treatment and then you're going to feel better. So I would definitely work with your doctor to address those labs and how you should best replete.
Brilliant. Thank you, Doc. Dr. Ackerman, I often get this question from my athletes. So it's my question. I'm not going to be putting one up, but and you mentioned things in around your calorie intake throughout the day. And a lot of my female athletes ask me about intermittent fasting. And so, yeah, your thoughts on intermittent fasting for a female runner who's perhaps over the age of 45?
Yeah, so I'm straight up telling you I'm not a dietitian and I don't do the research in that space per se. But we do know in some of our younger athletes who do intermittent fasting that it can really throw off their metabolism. And it can, if they're doing their training at a certain time of the day and they don't have the fuel for it, it's going to affect their performance. And sometimes they don't get enough makeup in terms of their calories later. So the timing of the food, the timing of the training, is important, at least in our premenopausal population. I know intermittent fasting is very popular, especially for people trying to get weight off. But if you're a high level athlete, it can sometimes get you into some trouble. So there's a subtlety there that I think needs to be addressed.
Yeah, I think I'm biased asking that question because I just want someone to hear it other than from my mouth. So if my athletes can hear it from yours, and then maybe, it's like when kids play up, mom versus dad, So
Yes.
that was really biased of me to ask. But
yeah, so I think I got your answer right. You didn't even tell me what to say.
Good. I love it. Thank you. It's not even like we planned that. So yeah, no, that's brilliant. Thank you. There are a couple questions coming through that I think are quite nutrition or dietitian specific, and again, you have mentioned that you're not necessarily a dietitian, or that's not your expertise, in terms of, let me just read here, like what, your recommendation on energy requirements, or what, how do people know, or where can they get that sort of information to know that they're matching their energy input to their outputs? I don't want to make that so specific for.
Yeah, so, the original work, and I didn't get into the slides, but the original work was really based on a cutoff. And so there were some great studies that were done by Ann Laux, where she took basically sedentary women or people that worked out less than 2 hours a week. And she was in a lab setting and she was able to manipulate their energy availability. And so energy availability is basically energy intake minus exercise energy expenditure normalized to fat-free mass. So if you had a DEXA, you could figure out how many kilograms of fat-free mass somebody is. And so using that energy availability equation, she found this cutoff of 30. So when people were below 30 kilocalories per kg of fat-free mass per day, they started having drops in a variety of hormones. However, when people tried to replicate those studies in different populations, they didn't find a pure cutoff. So the thing that we're realizing is probably in adolescence, it needs to be much higher because they're going through growth and development. It seems that men can get away with a lower energy availability than women can. And then when you get to our postmenopausal women, who the heck knows, because people aren't studying us enough. So it's really more about meeting with the dietitian to talk about how much do you need to cover your basic basal metabolic rate? How much are you expending through your workout? What have you done before? How much has your weight fluctuated? Looking at some of your labs and then having an individual discussion, because there isn't one specific cutoff for everybody.
Yeah, excellent. And as you mentioned, the entire team is involved in that process, and then so having that discussion with the coaches as well to make sure that the training loads aren't, outweighing those sorts of inputs as well. So yeah, definitely multidisciplinary approach there for sure. Judy's asking a question, and I know that she's saying, I'm sorry if I've missed this, but how do you lose weight without getting yourself into red SILA? So perhaps you're just giving an explanation around, that as a spectrum, and we're not saying you're not allowed to lose weight or you're not allowed to, monitor what you're eating.
Well, and I think, there's a lot of different ways to lose weight, but the key is you want to lose weight in a way that's sustainable and you haven't destroyed your body so that you've shut down your metabolism. And so I think the first thing most people want to do is just restrict what they take in their mouth by a lot. And they know that they're going to lose weight. And that absolutely works at first. But anybody that I've taken care of for a long time that tried that had trouble because their metabolism slowed down and then they started to gain weight. And so then they restricted even more. And then they were on this tiny, tiny bird-like diet and gaining weight. And that is so discouraging. So that's where it's helpful to do things incrementally. We all fluctuate in weight a little bit if we're busy people and we have different phases of our life, whether we're having babies or we're training for a marathon or we get injured or we're working a lot. Our bodies are going to fluctuate a little bit. And so if we are trying to, get some control back and decrease our weight a little bit, we have to go slowly. And that's where I think doing it with an expert to help us do it and not believe any of these one size fits all approaches That's the key. And I think especially if we're in menopause, we have to be a little bit more forgiving. I am not going to look like what I look like at 24. It's never going to happen, and I'm okay with that. But are there ways that I can be, keeping more muscle mass on? Sure, by doing more lifting than I needed to when I was in my 30s. So part of it is body acceptance. Part of it is making sure we're making gradual changes, not starving ourselves, and modifying our training a little bit so that we're getting more bang out of our buck.
Yeah, again, guys, I promise if any of my athletes are watching this, I didn't tell Dr. Ackerman to say anything about lifting, anything at all. Okay, so that's really, really good. But just again, a follow-up question from me on that was exactly that. Like some of the acute symptoms or things that were happening were, you said low testosterone, changes in resting metabolic rate, changes in the glycogen store. So all of that is going to affect your running performance, and that's low energy availability. And correct me, Doc, if I'm wrong. I think I've read a study that if you have low energy for as little as 4 days, you can start seeing some of those acute effects. Was that?
Yeah, so that picture, that diagram I was showing with like acute and then weeks to months and months to years, those acute ones, if somebody has, we call it problematic low energy availability. So problematic could be because it's prolonged. It's a little bit lower than it should be for a really long time, or it can be severe. And so if someone is really severely restricted, even for just a few days, then you can see some of those changes like T3.
Excellent. Yeah, so some amazing comments coming through. Thank you, guys. Just please hit the like and subscribe button if you want to see more of these. I know that S. Curtin asked this question at the beginning, so I do want to ask a chair for her as well. She's saying, what about endometriosis affecting that assessment process of REDS? She says she is post-menopausal.
Yeah, I think anybody that's having involvement of the menstrual cycle, whether it is they are postmenopausal, so I can't base their energy availability on if they get a monthly period, or they have endometriosis, so I can't base this assessment on their GI symptoms or their menstrual cycle. We have to use other body systems. So we can use the white blood cell count, we can use the T3, we can use body composition, we can use the training history and some of the performance surveys, because menstrual cycle can't be our only biomarker that we're able to work with.
Excellent. Thank you, Doc. There was a question, sorry, now I think I've lost it. And I'm going to mispronounce your name here, so I really apologize if I'm not getting that right. Sempagita, apologies for mispronouncing that. Can you elucidate to the reason why your blood pressure goes up due to the increase of low energy availability?
Yes, so let me explain that better than I did. So what I was trying to describe is orthostatic hypotension. So that means someone's lying down and they have a fairly normal heart rate and a fairly normal blood pressure. When they stand up, a healthy athlete who's pretty fit should not have a change in their pulse and in their blood pressure. What happens is if they're really energy restricted, they will have a sick heart. And that sick heart is not able to pump blood appropriately. And so their blood pressure just drops as they stand up. And then their heart starts to pump really fast to try to make up for it. So they have this increase in their pulse and they have this drop in their blood pressure. That is called orthostatic hypotension. The other thing that we see is somebody who gets bradycardic with training. So we know an elite Olympic athlete might have a low heart rate. A teenage athlete should not have a heart rate in their 20s. That's really scary, no matter how elite they think they are. So there are different cutoffs that we use for elite level athletes and for different ages of athletes. So in general, we say no adolescent should have a blood pressure a pulse below 50. And for our adult athletes, they really shouldn't have a pulse below 40 unless they've consistently been training and they are at that very elite level. And it's really about following patterns over time. If I have an Olympic runner and their pulse stays around 37 all the time, even when I see that they're eating a ton, that's a very different situation than you are a postmenopausal woman and your pulse has been 62 and now it's 32. That means something's happened that we need to address.
100%. Just a really positive comment here, which I thought was so great. Solar Powered saying, as someone who's been running since 1980, I really appreciate this information. I only wish I'd known it 40 years ago. And that's the joy of research and hopefully good quality research coming out. And there are a few questions of people asking when are we going to be getting more on postmenopause and Aliyah and RED-S, but yeah, thank you for that comment. I think that's
I will say that of all the people that we talk to and study, our postmenopausal women are my favorite because they are the most eager to be studied. We're all looking for answers, so it's a great crowd of people. Then hopefully we'll get you some answers soon.
Brilliant, thank you. And this is a good question, maybe just for reiteration. Sempagita again asking you. You mentioned self-reporting screening. Where are those? Could you get those on that website you mentioned?
Yeah. So if you go through the REDS-CAT 2, it shows some of the questions that you can ask, and specifically in the methodology paper and also in the primary, secondary, tertiary prevention, we talk about specific screening tools. So there's things like the Beta Q, the brief eating disorder questionnaire for athletes, different things like that. And in that document, it demonstrates who they have been verified in or validated in. So was this validated in an adult woman? Was this evaluated in a teenage girl? Again, menopause, we're all making it up because so little has been done in this. So, I think we kind of, as postmenopausal women, have to look at these different things and take them with a grain of salt and realize, all right, this might not have been validated in me, but does this questionnaire ask me things that I should be thinking about? Am I saying yes to a lot of these questions? Then I should be working with my doctor to investigate more.
Excellent. This is a great one as well. And again, perhaps I know it might sound like repetition, but just for understanding purposes, so it's not about restricting food intake, but about changing your exercise and your daily activities, or is it a combination of both? Is it adding? I know you mentioned carbs earlier, which I was also quite happy about. But yeah, just perhaps help Nature Bird with this.
I mean, again, it has to do with where you're starting from. So are you somebody that had a really perfect diet and everything was working for you? Or are you somebody who's just getting into exercise? Are you already fit and you're just trying to tweak some things? So I'd say for most of us, we were in a pretty good groove at some point where we felt like, hey, I'm getting away with this amount. This is how much I exercise. This is where I feel good. This is where I'm allowed to perform at the level of exercise or competition that I want to, and have a job and have kids and. As you go through menopause, it's harder to pull off and keep firing at all cylinders in your work and personal life and keep doing the same training and eat the same things. So there's no question I didn't even get into this, but we have to get more sleep. It takes us longer to recover. We have to start adding in these extra things like PT stretches and strengthening things because of muscle deficits and injuries that we don't, recover from as quickly. And the same thing goes with nutrition. And the same thing goes with how we need to modify our training to do the strength training. So I know I'm being sort of vague, but it's because there isn't a one-stop solution. I'm not trying to sell anything. I'm not going to tell you need to follow a certain plan or a diet. It really does need to be individualized.
Yeah, exactly. And I think that's such a key point. And you mentioned it in towards the end of your presentation there about, just being careful or aware of the information that you're being sold, on social media and I mean, we run a running through menopause training framework at Coach Peri. And I mean, it mentions all the, some of the things you spoke about there, recovery and strength training and so on. But, I think just as a caution to everyone listening, take your information from evidence-based people. Don't just listen on what happens on TikTok and Instagram, because I think there is just so much out there that is then confounding and confusing, when you're struggling so much to lose weight and train hard and so on. Yeah. Good. And then last points I just wanted to mention, this is from Melissa. I thought this was great. Melissa just saying, you guys are brilliant. Thank you for sharing. Well, probably you, Dr. Ackerman, not us.
No, I think
you are brilliant. Thank you for sharing and your research and knowledge. I'm so excited to know that this work is going on, especially for women, and really look forward to future menopause research. So yeah, thank you for that. And yeah, so Dr. Ackerman, from my side, thank you very, very much. I know you've done one of these for Coach Peri in the past. I've heard a couple of your talks at some academic conferences, and so it's always amazing for me to hear from you. So thank you very much. And any parting shots for you that you want to leave at the end of this webinar?
No, I just think I'm glad there are people that are interested in REDS and preventing it. And I'm really glad that there is this community of really active women. And it's fantastic that we're all really pushing for change and trying to get more research out. So I'm one of you. I also want answers. So we all have a vested interest in just, encouraging researchers and encouraging people in this space to spend money on research on us, because we're not going away.
Yeah, exactly that. And I love that, because that's we want to change that. We want to change that narrative of, oh, you're done now, you're finished. There's nothing more we can do for you. And so, you being one of the leaders in the field, thank you for that, and for your work, and for your time today. So really, really appreciate that. And for the presentation and everything. So enjoy the rest of your summer in Boston. And thank you very, very much, Doc. And we hope to speak again soon.
Thank you. Take care.
Thank you.